Good evening, everybody. Welcome to tonight's program at Walton Library, the long and short of healthcare in the U.S. I'm Michael Bellicosa, Community Engagement Manager here at the library, which means I get to organize our adult programs, working with many collaborators in the community. And our presenters tonight actually began discussing this topic with us over a year ago, but they really wanted to do this in front of an in-person audience. So as soon as we restarted those in September, we got this right on the schedule. We got two great presenters tonight. Mike Boswood, the long of it, is the former CEO of Truven Health Analytics, Thomson Reuters Healthcare and Science, joint MD of Elsevier Science. And he's also a trustee of the library. Joe Magnano, another trustee, is the short of it. And he's the former Global Head of Legal M&A, Finance and Investments at Zurich Insurance Group. So between them, they have decades of experience in understanding and explaining complicated business issues and are well served in the intricacies of the healthcare and insurance industries. I'm going to turn this over to Mike and Joe.
Thank you. Thank you very much, Michael. Is the microphone on? Yes, and so is Joe. So we were going to do a little routine about the long and short of it, but Michael did that for us. Which one is which? Exactly. So we'd like to thank the library for making this possible, and thank you all for coming. We started talking about doing this a while ago, as Michael said.
I just want to also thank the library.
Oh, sorry, Joe.
Welcome. Thank you all for coming. I did want to tell them one thing about this.
Oh, that's right.
This is the first time ever that I've given a presentation where I have advertised, publicized in advance. I even put it in the title, in the photos, how short I am. So, thank you.
So we go for these walks on the NRBT. There's me loping along. There's your and we thought, well, this would be interesting to try and share some of our experience of life and work. And so we decided we would pick a really soft, easy topic to begin with, namely healthcare. So we're going to talk today about the healthcare system in the US. And I'm sure some of you will agree that all is not well with the healthcare system in the US. It has significant issues. And we're not going to dodge these, but we're not going to kind of make a meal of it either. We're going to kind of trot through those issues as lightly as we can. Important to emphasize, we're talking about healthcare. Healthcare is a business, and it's defined by the business relationships of the parties that are involved. It is an entirely different thing from medicine. We have nothing but admiration for the people who work in medicine, and we both benefited from their good efforts. There's a couple of other things.
So what we're not going to do is advance political agenda. We're not going to talk about things through a political lens. We also we're not going to talk about COVID, except to point out the problems with the healthcare system that existed pre-COVID, that COVID put into the line.
That said, we have opinions, and we're going to express those freely, and we expect that you will all accept them unreservedly and without question.
Now that's Mike's British humor again. It comes up once in a while, and it's sort of like, what he really means is he wants us to consider. We want you to consider our opinions thoughtfully.
And I just like to point out that Joe is a lawyer. Well, okay. Right, we're going to get started now after that lengthy preamble. What we're going to get started with is an extremely brief history of healthcare, actually healthcare coverage in the US. And that really started with doctors and hospitals getting together to create Blue Cross Blue Shield mechanisms for insurance in the 1920s and 30s. But the big thing that happened was in the late 1940s and 1950s, after the Second World War, when companies started to offer their employees insurance, partly motivated by the fact that there were strict wage controls at the time. America was emerging from the Second World War, as were a lot of other countries. And these inducements with a tax-free status to offer benefits enabled employers to compete for labor. And the labor market after the Second World War was very competitive. The poster child for this kind of activity was the Big Three in Detroit, who jumped into this, created a fantastic benefits and pension scheme to the point where in the 1980s, the cost of the healthcare in a GM car exceeded the cost of the steel in the GM car. But that took a few decades to evolve. And in the 1950s, the big push was for employer-sponsored healthcare. In the 1960s, Lyndon Johnson's administration created Medicare because the elderly were not included, they weren't working, so they weren't included in these private schemes, company-sponsored schemes. And Medicaid, which was for the economically disadvantaged who might be working, but whose organizations were too small to offer healthcare. Medicare and Medicaid marked the entry of the government into the healthcare business. The government is heavily involved in the US healthcare system and has been since 1964. In fact, now it's roughly 50-50 in terms of public and private. Now, the interesting thing is, between 1965 and 2010, from a structural coverage point of view, nothing actually happened. A huge amount happened with the healthcare system as it existed, all kinds of developments with Medicare, all kinds of developments with how insurers provided insurance, but nothing structural happened. The Clintons, I can put it that way, tried it in the 1990s, and it was not successful. So in 2010, the Affordable Care Act, also known as Obamacare, was passed, and this was the first piece of legislation in over 50 years that actually expanded insurance coverage in the US. In 2012, before the act really kicked in, 46 million people living in the US did not have insurance. In 2019, that number had come down to around 30 million. But it's estimated that in addition to that, there are still 30 or 40 million people who are underinsured. And we will talk about that a bit more later on in the presentation. So the point here is that there never was a comprehensive plan for a US healthcare system. What we have now is the product of circumstance and how that circumstance was perceived at the time. And as a result of that, there are some really big things that were never really considered.
Thank you. And don't do the next slide yet.
Okay.
I want to give my introduction.
I have the clicker, so I'm in control.
So there's no plan, and that creates some issue. A big issue is because there was no plan, we never, as a nation, addressed some fundamental issues. Question. Because of that, we have one. So now I'm going to turn to what those questions and issues are, and failure to address them, the problem that has created.
Ready now?
Yep.
There you go.
Okay, what's the first fundamental question? Should healthcare be a right that cannot be taken away from you? Or is it a privilege that is conditional, can be revoked, can be altered? This is a really important question. And as a nation, we haven't addressed it. So why? What's the bad part of it? Would you might refer to the Affordable Care Act in 2010. the Affordable Care Act took a nod, trying to address the issue of universal. How did it do it? It expanded Medicaid. It created the exchanges where they subsidized low-income people to buy insurance on the exchanges. And it created something that is not there now, which is the mandate. So that was the attempt to make it universal. So you say, okay, well, we haven't addressed the fundamental problem. So what is the problem that we haven't addressed that fundamental question? The problem is that the Affordable Care Act has been under attack for over a decade. And the reason it's been under attack is because as a nation, we haven't answered the question of whether healthcare should be universal. It should be a right or a privilege. Second question. What's the right balance between private and public funding? Put another way, should healthcare be affordable to all? Until we answer that question, we will be debating the issue of how much public money should go into healthcare endlessly. There will be no coordination between public and private sectors, and everybody will be surprised to learn, as Mike mentioned earlier, that the public-private split right now is about 50-50. 50% is coming from public money. Third problem, should there be a focus on prevention? But without a plan, a healthcare system naturally gears to treat problems, not to prevent problems. Taking steps at prevention, at creating a strategy for public health, requires planning. Fourth problem, how should value for healthcare be measured? Should it be fee for services? Should it be measured according to activity? Or should it be measured according to outcome, according to results? If it's measured according to activity, it's like a fee for service. What happens with fee for services? You have a natural incentive to increase activity as much as possible, to increase the number of people as much as possible, and reduce the cost as much as possible. Until we have a plan, the default is to pay for activity, not to pay for outcome. Outcome being quality of care at a lower cost. And finally, the fifth issue is, hey, ladies and gentlemen, there are these developed countries out there. Hey, you know, like, how are they doing? What can we learn from them? Have we tried to come down? Well, I'm going to try to turn it now, turn it over and look at these other systems in other countries and what we can learn from them. And in the meantime, as we look at these, remember these fundamental questions. Is it a right or a privilege? Should public money be used to make it affordable for all? So now we're going to go to these. Don't turn it yet. I got to give the introduction.
Oh, okay.
So Mike and I put our heads together and we said, how much time do we have? 5 minutes to describe healthcare in the rest of the developed world. It's a little bit of a challenge. So we tried,
You're up to it, Joe.
I'm up to it.
You're up to it.
So we came up with 3 paradigms, 3 models, and we tried to fit everything into these 3 models. We picked some countries that are examples of those 3 models, and we try to pick the salient features of these models, not bear down a lot of detail, sort of instructive, so we synthesize it. So we can understand it and make comparisons to the United States and make comparisons among these different models. So the first one is UK, which is basically Denmark and Sweden also have a similar model. What is this? This is we'll call it socialized medicine. That's the best description. Now, how we're going to try to explain them in a simple way. So basically, there are fundamentally 3 roles, maybe 4 roles to include patients, but there are basically 3 roles. There is a payer, which is the government, the insurance company. There's the provider, which is the physicians in the hospital. And there's the administrator, which is normally government or the insurance. Those are the basic three roles in the classification. So I'm going to describe these three different models based on like who the payors are. In the socialized medicine model, it's very simple. The government is payor, provider, and administrator. And it's, it's great. They do everything. Well, it's not so great because what happens is, as everybody knows, in the UK, you have to wait weeks to get your hip replaced. You can't take that with that Alzheimer's pill that costs $10,000 a month. You can't do that in the UK because before the government pays for any drugs, it has to be shown to be cost effective. So that's a socialized medicine model. How does it compare to the United States? We will see. Next model, please. Okay, this is easy to understand. It's the Medicare, Medicaid, or all model. And here, the government is the payor and the administrator, and the provider is a mix of public and private. You're sort of familiar with this because Medicare and Medicaid. But in these countries, which is a good example of Australia and Canada, basic coverage is, guess what? Mandatory. You gotta have it. Extra, but they allow you to have extra coverage. By the way, I didn't mention the UK. You are allowed to have extra coverage. There is private hospitals, there's private insurance. It's extra. Very few people have it, but you can do it. In these countries, you can get extra insurance, but you just have to pay for it. It's not part of what the government is doing. And the third thing, which is revealing characteristic of these is that government sets prices for basic coverage. The government is in there negotiating with the drug companies, with the hospitals, with the physicians on the pricing. That's the second paradigm. The third one is something, a country, a paradigm that I'm very familiar with. That's Switzerland, because I lived there for 2 years. And there, the government said, you guys do it. The government doesn't do anything. It's not the payer, it's not the provider, it's not the administrator. It regulates it. It tells you that basic coverage is mandatory again. They subsidize lower income people so they can afford to pay for insurance. Extra coverage, again, is optional. If you want the uber arts, the super physician, you want a private room with a view of the Lake Zurich? Yeah, okay, okay, that's extra. Government sets the prices for basic coverage and standardizes the policy. So even though it's not the administrator, it's standardized. And finally, no profits are allowed for basic coverage. You can't make profits for basic coverage. When you profits, you go to the rooms with the views of the Zurich, but not for the basic coverage. Now, what happens in Switzerland? I know the Swiss government. I wasn't surprised when I learned about this. In Switzerland, if you don't have insurance, forget about the mandate, a little tax. Might be wrong. But in Switzerland, what they do is, if you don't have insurance, don't worry. They'll give you a couple months grace period, and they'll buy it for you. And they'll start charging you 30 to 50% more than you would have paid had you bought it. That's how they do it. So that's Switzerland. Now, we asked the earlier question, what can we learn from these basic models? Let's see what we can learn from these basic models. Number one, basic coverage is required and affordable by all. Is required and affordable by all. Number two, additional benefits are optional. You can do it, they won't prevent it. Number three, government sets prices for basic care. And so now Mike will demonstrate visually and audibly how the US compares with these other systems. Mike, over to you.
Thank you, Joe. So, spoiler alert, the US healthcare system does not stack up very well against these kind of socialistic European models. And the measure is performance and cost. And we are going to actually see what that looks like graphically in a moment. But just to run through this checklist quickly, the amount spent on the US healthcare system is around 18% of GDP. In actual money, that's about 3.5 trillion. How can you possibly imagine what 3.5 trillion looks like? Well, a point of comparison would be it's about the size of France, the economy of France, that is. So we have something that's as large as a fairly large country that represents the economic cost of healthcare in the US. So it's expensive. It doesn't perform very well, and we'll see that in a moment against 5 core measures looking at US healthcare in relation to some of these other countries. And as a result of that, you take cost, you take performance, and the relationship between those two is value. And so you can say rather emphatically that US healthcare does not provide value for money. It consumes a lot of money, but it doesn't provide value for money. And just 2 bookends to these sad statistics, which might are useful, is that in terms of life expectancy, the US comes 28th of 35 OECD countries. And as revealed in a recent article by Atul Gawande, who's a very well-known writer on healthcare, also an active surgeon at Mass General, the life expectancy in Costa Rica now exceeds that in the US. And that's a whole different story, but the basic reason for that is that they don't have a lot of money. They focus on the basics of primary care and treatment of chronic conditions. And the US has a very high infant mortality rate. Of course, it varies hugely amongst different economic and racial groups, and it varies hugely regionally, as most things pertaining to healthcare do. But the US ranks 33rd out of 36 OECD countries. So what does this actually look like? There is an organization called the Commonwealth Fund, which carries out work relating to healthcare. It's existed for 100 years or so. Hang on there. And it doesn't take lobbying funding and is a well-respected objective source of information. So recently, in August, they produced a report looking at US healthcare in relation to other countries. And the performance calculation they made was in 5 categories, and this is quite interesting. But before I get there, I think Joe wants to say something.
Well, you forgot to put the US on this chart.
Oh, I did, didn't I?
You forgot to put the US on it.
It's here.
Again?
And so the US is, there's a nice kind of a tail from that's Norway at the top. Norway, Scandinavia, relatively small number of people, relatively homogeneous, North Sea oil. Of course, they'd be good, right? And then it sort of dwindles down to Canada, and then it drops right off to the US. There are 5 measures here: access to care, the care process, administrative efficiency, equity, and outcomes. And interestingly, the only measure that the US does well on is care process. And that makes a lot of sense, in the sense that once you get through into the medical system and you see the right people, the care process in the US is really good. The issue is with all the other things. So let's now look at affordability. This is the, it's the same. In the number 1 performing country for affordability is the UK. What's the reason for that? When the National Health Service was set up in the late 1940s, the overriding principle was that care should be free at the point of delivery. If you're looking to have appendicitis, go to the UK. They're great at treating things that are serious and immediate, and they'll do it for free. They won't ask you where you're from. You will get your treatment, and then you'll be able to move on. And there's a fairly broad range there in terms of affordability. And clearly, in Switzerland, if you don't behave the way the government wants you to, you'll get penalized, and that might account for the fact that they are where they are, I'm sure. But once again, surprise, the US is last in terms of affordability.
Michael, you really have to be more creative with the sounds. We all heard the sad trombone sound. Trombone sound. Can you please, like,
What's a trombone?
it's a sad trombone.
Oh, okay.
Yeah. So
Yeah, it's
why don't you come up with
a
something more
soul
creative?
trombone.
Would
Okay.
you come up with something more?
All right, we'll try something more creative. So now we want to look at the performance of the US in terms of value, which is, of course, the combination of affordability and performance. And here you see how the other countries cluster, which they do. But when we impose the US on here, the following happens.
We negotiated that sound.
Apparently, that's known as a raspberry, both in the UK and the US. I didn't know that the term raspberry applied here. But, I mean, it's remarkable. We have to shrink the scaling in order to get the US on the graph. And so, what are we looking at here? In these terms, in terms of performance, in terms of value, the US healthcare system really is pretty much of a train wreck. The interesting thing is that it hasn't really attracted the kind of competitive pressure that you would think it would. In the 1970s and 1980s, US automobile makers kind of lost the plot. What happened? Japanese automakers arrived, the Europeans arrived, and a fundamental and big change started to happen in the way cars were built, in the way that they were quality controlled, and so on and so forth. What we're going to see here in the future is more competitive pressure created by the poor performance of the industry. So that will take time, and we're going to talk about what that might look like towards the end of the presentation. But now, I want to turn things back to Joe, who's going to talk about insurance coverage and the four-legged stool.
Thank you. Thank you.
Right.
So again.
I feel like I should retreat.
No, you don't have to retreat. It's okay. No, okay. So we talk about the health insurance in the United States. I'm going to try to summarize it very quickly. You're all very familiar with it. So it's basically the four-legged stool is employer-sponsored insurance. About half of it, the employer buys insurance or self-insures. He hires an insurance company to administer it, and generally the employer pays between 66%, about 2/3 to 4/5 of the premium. Okay. And then we have about 1/5 each in Medicare and Medicaid. Everybody knows Medicare covers over 65, permanently disabled. Medicaid covers the low income, the disabled, and the blind. And then we have, as Michael used, I think he used 30 million. Our uninsured, it's about 10% are still uninsured, and 7% are by private insurance. And generally, the split between, as I mentioned earlier, public private funding is about 50-50. So that's how the basically very simple terms how the insurance industry, in the health insurance industry in the United States is. So now we're going to go to what's wrong with it. We saw those numbers before, and we saw the sad trombone and what's the raspberry. So what's causing that? What's wrong? And again, we try to analyze it. Are we going to take questions? I'm going to wait till the end.
I think we'll wait till the end.
Can we wait till the end? Is that okay? Because so I can make sure we cover the material. Thank you very much. Okay. So now there's something wrong with the stool, and it's going to. I don't have any sound for that.
Do you want me to provide one?
Okay.
We'll do it again.
That was not rehearsed. Okay. Next slide. Okay. Okay. So now, So what are the flaws in the system? So what are the basic flaws that threaten to collapse the stool? Okay. So now I'm going to do a sidebar with the audience.
Okay.
Okay, so you're going to be, you're going to not listen to this. So when we came up with this slide, I told Michael that it really is, there's four things we're going to say is wrong with the system, and each one begins with the word no. I told Michael that's not really correct. It should be little or no. So Michael said, if we put little or no, and Michael can even hear it. If you put little or no, it just doesn't sound right. So we got to put no this, no this, no this. And I said, given our relative size, I gave up. I let him that argument. But I'm going to defy you now, and I'm going to say little or no. Got it? Okay. Little or no. It says, okay, little or no. So we talked about the other systems, and we know that the government, the other system, is the payer and the administrator. Or the government, in the case of Switzerland, standardizes the policies and the pricing, so there's coordination between the payer and the administrator. In the United States, you have the federal government, the state government, and insurance companies, and there's no coordination. There's little or no coordination among the ways. That's the first problem. The second problem, little or no pricing consistency. So the same procedure in the same hospital gets charged differently. Why? Because the payer and the provider negotiate. Hospitals and the insurance companies negotiate. The hospitals and the government negotiate on the basis of each diagnosis related group, DRG, and other things, other codes, and they come up with different prices. So the same procedure might cost differently. And the other problem with pricing is I'm going to now travel to Alice in Wonderland, where up is down and down is up. What happens to the uninsured? The uninsured don't have an advocate by their side. They don't have the government. They don't have the CMS negotiating prices for them. They don't have insurance companies negotiating prices for them. They're out in the cold. They are charged, it's called the charge master rate, the retail rate, which is at 3 or 4 times what Medicare or Medicaid pays. So the upside down thing is that the uninsured pay the most by far. They're automatically charged the most. Of course, then they can try to negotiate over price. Okay, that's pricing problem. The third problem is there's no funding plan. If there's no coordination, how could be the payers doing it? In fact, not only is there no coordination plan, a funding plan, there's open hostility. The federal government, for the Affordable Care Act, knocked on the doors of various states and they said, I'd like to give you some money. I want you to give me money so you could expand Medicaid and cover more people. I mean, that's wonderful. And guess what? The cost of expanding Medicaid will cover more than 90% of that cost. And what did the state say? 36 states said, yeah, that makes sense to me. And 14 states said, leave the money, I don't want it, leave it on the table. 14 states have never expanded Medicaid. So they're fighting about funding. And the fourth, little or no predictability of insurance benefits. We talked about before about insurance coverage is based on the vagaries of age, employment, income. And when you get a procedure, I had some procedures done last year, and when I got the bill, I had no idea what I was going to have to pay. I had no idea how much it would cost before, how much my insurance would cover me, how much I would have to pay. So there's no predictability of insurance benefits. And Mike, what does this all mean?
Beats me.
Okay.
So what this means is the following. There isn't a sort of a generally accepted understanding of what things cost. And that's an incredibly basic thing. We know more or less what a television costs. Right? We know more or less what a car costs. We definitely know how much the extremely expensive coffee machine with a 600-page manual that doesn't work properly costs, but I digress. We don't have a sense of what things cost in healthcare. A colonoscopy, there's a variation of 4 times in terms of cost for a colonoscopy between around $1,200 and around $4,800. A knee MRI from $900 to $4,100. What are the reasons for these? The reasons for these are different deals agreed between insurers and providers. They have to do with the application of a coding system. Joe mentioned DRGs. Underneath the DRGs, there's something called ICD-10. ICD-10 consists of 70,000 up to 7-digit codes that define every medical condition and procedure. These are the basis for how providers charge insurers. And it's a system which invites gaming, because if the providers can upcode, they can generate more revenue. If the insurers can get them to downcode, they can save money. There are extremely successful businesses in healthcare which exist to help, on the one hand, providers to upcode, and on the other hand, insurers to downcode. Is this a productive use of time? And what comes down, when it comes down to it, your money? It really isn't, but it's one of the dynamics within the healthcare industry which result in a lot of confusion and indeed a lot of pain. Medicare is an extremely substantial entity within healthcare, but it doesn't really, and it's not supposed to in every respect, act as freely in the marketplace. Right now, there's a discussion about allowing Medicare to negotiate drug prices, and it looks as if that will go through, but not yet certain as of today. And so what happens with this charge master that Joe described, which is the high level of pricing that no one gets charged except the people who couldn't possibly afford it. So it becomes like a Dutch auction where you start high and go low. Medicare pays prices which are about 2.3 times lower than private insurance. And so there's this big space in which these price negotiations take place. And the beneficiaries, quote unquote, of those negotiations, who are, I would say, us, the consumer, and companies that sponsor healthcare, they're not at the table when those discussions take place. And then you have regional variations, which are sort of baffling. But here's a piece of useful advice. If you need a procedure done, try to avoid being in Wisconsin or New Hampshire, because 20% of these things cost substantially more in New Hampshire and Wisconsin. Who knew? Alaska is very expensive, but that sort of makes sense because of where it is. So if we think about this basic sort of dysfunctionality in the way that the system interacts, then we can identify some anomalies in US healthcare insurance and in the system as a whole. If there is an underlying principle in the US healthcare system, it is that there should be freedom of choice. I attended a no-notes meeting a few years ago now, where there was a head of a very well-known insurance company, which will remain unnamed. It was Aetna. And the CEO then of Aetna said, we were talking about healthcare issues and what needs to be done about them. He said, the American people will never give up choice. Well, the anomaly is that they are. And that's because insurance plans have become more restrictive. The insurance companies agree deals to create networks. Going out of network is expensive. There are high deductibles involved. And so this concept of freedom of choice is being eroded. Now, I've explained how the economic interests of providers and insurers are in direct conflict. However, when it comes to us they get together and they say, we won't be transparent over pricing. There's one thing, and I think there's only one thing, I would guess there's only one thing that the Trump and Biden administrations agreed on. And that was that there should be pricing transparency. And that when insurers and providers make deals, they should be transparent as to what those deals mean for the people who are going to benefit from it. But the industry has objected to this. And now rules that were supposed to go in place in January have been put off by as much as 2 years. And we'll see what happens then. So there's a kind of locked in situation with insurers and providers. And so these decisions about how much is charged appear, it says here, they are complex and appear arbitrary. And any of us can read stories about this. The most recent one that I read was about a chap in Tennessee who was working in construction. He moved there with his wife and they wanted to set up their own business. And they were insured. And he cut his foot on the construction site. He went to the hospital. They said, it's okay, you're covered. They stitched him up and sent a bill for $6,000. That being $1,000 per stitch, which seems, a little extreme, of which he was asked to pay $4,000. His wife then fell ill and was so worried about this, she started looking for a different hospital. She eventually found one. She was diagnosed not with COVID, but with something that was potentially very serious, but got treatment in time and got billed $190. And they're both got the same insurance coverage. So these are real situations which create real problems for people. And we have seen how, and Joe was in insurance, and he will tell you the function of an insurance company is to not pay claims, right? It is in a way
To reduce risk and to minimize things. Yeah, I think that's
to not pay claims. So yes, to reduce its risk and pay as few claims as possible within the constraints of its function of a responsible business. Of course, realize this. But these restrictions are becoming more and more intrusive in healthcare. They used to be called high deductible health plans. There's a very clever marketing twist that's been put on high deductible health plans now. They're now called consumer-driven health plans. Doesn't that sound nice? The thing is, it really isn't true. They're health plans which you can choose to take. When you choose them, we'll talk about this in a moment, you have to be quite careful as to what the results are. And so let's talk about, it's in the title, what are some of the myths and misconceptions about US healthcare? It works. It really doesn't. As a system, it really doesn't. There's great medicine. I was at the same meeting I referenced with the head of the insurance company I didn't name. There was the head of a famous health system called the Cleveland Clinic. And I was kind of learning the ropes at the time about healthcare. And after we both had a glass of scotch, I decided to be brave and make a comment about US healthcare as I saw it. I said, it seems to me that US healthcare has great medicine. In the US, you have great medicine and terrible healthcare. And he absolutely agreed with that. It's a free enterprise system. It really isn't a free enterprise system. Not only is, as Joe says, it's 50-50 between public and private, but it's heavily regulated. What the federal government tries to do is to sort of push the industry in a certain direction. And the industry, as with the transparent pricing, the industry reacts. There isn't a single significant development in healthcare that hasn't been opposed by most of the constituents in the US healthcare system. It's best in class, no. The Affordable Care Act was a good thing because it increased coverage, but Obamacare is a bad thing. It was a federal intrusion on the rights and states of individuals. They are the same thing. We all know that. And I have this written down of course I can't find it now, but 3 years ago, approximately 30% of people surveyed did not know that these two were the same thing, and the approval rating for the Affordable Care Act was significantly higher than the approval rating for Obamacare. They are one and the same thing. Over to you, Joe.
So the uninsured can always get treatment if they need it. Yes, they can get treatment if they need it. The uninsured will get treatment if they need it, but as we talked about before, they get charged later, as also Mike mentioned. So they do that at a staggering, potentially staggering cost. This next one is, yes, the U.S. provides world-leading treatment for medical conditions if you can afford it, or if your insurance policy covers it. The Commonwealth Fund report, where we saw those charts, they ranked the U.S. as last, number 11, World Country Survey, in terms of accessibility because it's unaffordable. They surveyed the people, and the highest number of people, percentage of people that said, I don't know if I can pay my medical bills, I don't know how much my insurance company will cover me, was in the United States. So in terms of access, we're not good. Number 3, once you reach the age of 65, Medicare will take care of you. Now, at this point, I got to talk about original Medicare, Part A and Part B, because if you go to the Medicare Advantage plan, they're all over the map. But with respect to original Medicare, there is no annual out-of-pocket maximum. For those who are not yet on Medicare, that's surprising because you always know that in the year you're not paying more than a certain amount. Not with Medicare. There's no annual out-of-pocket maximum. There's no dental, there's no vision, there's no hearing. You got to get separate policies for that. If you go abroad, don't forget to buy your travel insurance because Medicare is not for you abroad. And finally, as the case of all insurance, there's no long-term care, which of course is elderly people need long-term care, and it obviously doesn't cover it. So you're not covered for Medicare. And the last one is about, I love doctors. My doctor, I have a great doctor, and when I saw her for my annual physical a couple weeks ago, she kept on saying, according to the book, we should be doing this. According to the book, we should be doing this. I thought she was a little bit stressed out. Doctors are human. They have problems. But interestingly, they did a survey of doctors pre-COVID. 33% were in depression or seemed not. There was a special word they used. They were depressed or disengaged from their patients. And they tried to figure out why. One was, have you ever been to a doctor and they have their head in the computer? They barely come up to see you, and they're typing away. Electronic health records is one thing. The other thing is accountability. I was referring to my doctor who said, the book says this, the book says this. They don't feel they can make their own decisions. They have to go according to the book. And the third reason is the administrative all the people who just trying to crazy. So those are my myths and misconceptions.
So on that happy note, why don't we strike a more positive tone and talk about COVID? Oh dear. So let's just.
I told you we wouldn't have to talk about COVID
except for this. And I don't think we need to dwell on this. Could we perhaps leave it that somehow COVID caused lots of people to hit the crazy button? And that it has exposed, or perhaps not exposed, emphasized a degree of dysfunctionality in the political sphere as much as or more than within the healthcare system itself. And none of that, in our opinion, has been in the least helpful. It is perhaps instructive now to look at what's going on in Europe, which has these health systems that tend to perform better. And what they're doing there is first in Austria, then in Germany, others will follow. There are vaccine mandates. Right? In the US, we can't agree on a mask mandate. And so as long as this goes on, it's going to impose more challenges on the healthcare system here. And I don't have a vote, but you all do. think about that when you're voting. There is, however, one extremely good thing that COVID has imposed, and we should all hope that it continues. And that is, it has allowed for remote access to doctors and medical staff. And that access was limited in every state because there were restrictions about who you could contact or how far away a doctor could be in terms of remote interaction. And many states passed legislation to allow for those rules to be relaxed. They're now looking to either make them permanent or reimpose restrictions. If they do the former, it will be a big benefit for the healthcare system. So now we're going to turn things around a little bit.
We're going to go from the cloudy, rainy part of town to the sunny, more optimistic part of town.
Okay.
Finally,
so there are
yes.
reasons for optimism.
Yes.
And they are, some of them are, and there's someone in the audience who's so relieved.
Yeah.
Finally, we get some
But we're getting to the end, so we're going to hurry up on this.
no, potentially good news. I figure we've got 7 or 8
No,
minutes.
I'm just kidding.
No. So what is a good thing? It's a good thing. Sounds like a song, that the ACA is here to stay. Whether you like it or not, the fact that it was passed by Congress, it was signed by the president over 10 years ago, and it's been questioned almost ever since. But finally, it's not going to be repealed. The fact that in its current form, no mandate, but with Medicaid expansion, means that people can start to think about the future with the Affordable Care Act and do some longer term thinking about how to leverage it. And the good thing about the ACA was both the good thing and the bad thing. It was almost too clever, because what it says is we're not going to fundamentally change. Joe alluded to this earlier. We're not going to fundamentally change the US healthcare system. We're going to expand it via Medicaid. We're going to have a mandate that's gone now, but we're going to create these government exchanges so people have access to the possibility of insurance. But it didn't fundamentally change the system. Those ideas can now be advanced. And then there are developments, which Joe's going to talk about, which are designed to change the model that we all experience or have experienced in the past.
Did you know that in 2010, Affordable Care Act gave $10 billion to create the Center for Medicare and Medicaid Innovation that developed alternative payment models in terms of delivery systems? And that's what that's the value-based care we're talking about. Originally, I talked about we pay for activity, not for results. Well, I'm happy to report that in 2017, 33%, according to sources we've read, 33% of healthcare expenditures were for the alternative payment models. What are alternative payment models? They reward quality, low cost, by putting risk on the provider. Joe, give me examples. Okay, here's some examples. First one, the most obvious payment model is capitation. Fixed amount per person per period of time. Bundle payments. Fixed amount per person per episode of disease. So you have a problem, you give them a fixed amount, and you do everything for that particular disease until that is cured. So it's somewhere between capitation and pay for activity, pay for service. It's fee for episodes. So there's risk associated with that. The other one is global budget, another alternative payment system. You get a budget per group of people per period of time. If your costs come in less, you pocket the profits, if costs come in more, that's your problem. Accountable care organizations, you've heard of accountable care, you'll hear of accountable care organizations where they are capitation sites, where hospitals and physicians team up and share risks and rewards. Those are value-based care. They're growing. That's terrific. We're moving away for fee for activity to fee for before you tell. And now the next one is my favorite, technology, disruption. So when you hear disruption, you sound, that sounds terrible. Disruption, it's terrible for the industry. In the insurance industry, that I mean, they're talking about technological disruption. It's horrible for the business, but for the consumer, it's good. Disruption is technological innovation that improves the quality of the product for the consumer. So again, examples, best way to describe it is examples. Technological innovation in healthcare is creating better access to relevant healthcare data, better access to healthcare via telehealth, virtual health, artificial intelligence and machine learning about that they detect problems early so that you can fix them before it becomes difficult to fix. Big data collection. You've heard of blockchain database technologies, Internet things. They are causing, according to scientific breakthrough. This is really terrific stuff. I thought I gave a positive.
No, I thought that was really good. No, I was up there. It's a good thing, in our opinion, that the government will not take over and create a socialized medicine system in the US. Why? Because the cost and disruption caused by doing that would be overwhelming. It just isn't a realistic possibility. And therefore, and we see this now with the Biden administration, they're backing off from Medicare for all, they're backing off from the socialized medicine model. If that question had been answered differently in 1948, when President Truman had a proposal on his desk for a universal healthcare system, then it would be different now. But he didn't go ahead with that because things were warming up or not warming up, getting colder with the Soviets, and he didn't want to introduce something that looked as if it was socialism pure and simple. And therefore, now we should move on from this debate about the government takeover and deal with what we've got in front of us. And the last one that we've got on this list, I'll just do with very quickly. The industry is going to continue to consolidate. There's huge motivation or financial motivation for re-gearing, for integrating providers and payers, and for creating integrated services. A lot of the consolidation can be positive, especially if it involves players who haven't hitherto been big players in healthcare. I put except when it isn't, is because when that happens in a region where there's very little choice as a result of the deal, and Sutter Health just got pinged for this in response to someone bringing an antitrust suit. When choice is removed, then what's happening is that the organization that's doing that is creating pricing power. But for the most part, consolidation is good. What we want to do, and this is close to the end, we want to talk about what all of you and we can and should do in response to all of this. And there will be more sound effects. So I'll start it off. The first and most important thing for everyone who is going to interact with the US healthcare system, which means everyone, is safe. Because you need a cushion. It won't necessarily come to that. But there are ways to protect yourselves. In a recent article, a financial expert said, put aside 10 to 15% of your salary to prepare for retirement, and preparing for retirement is, of course, preparing for, not exclusively, but to some degree at least, preparing for healthcare costs. If you have a high deductible health plan, you can open a healthcare savings account with pre-tax dollars. And you can also access it without incurring tax. It's a highly beneficial thing that is available for those who've got high deductible health plans. There are other ways that we can all save. I guess what this is saying is Don't wait for something bad to happen and get caught out. Be forearmed in terms of that.
That was me and Mike having an altercation. We decided to record that.
I won.
That was good.
Fine. If you're mistreated by the system, don't think you've been rejected. Don't think that somehow you've done something wrong, because these big institutions are suggesting that perhaps you did, or behaving in ways that don't seem reasonable. It's a daunting thing to take on organizations, be they providers or insurance companies, which have huge resources and assets, but it can be done. People do it. And if you dispute a bill, then often you will be able to get it reduced. They don't like publicity. Calculate. I don't know about you, but when I was in this time of the year and we had open enrollment, I'd think, oh, that's a nuisance. I'll just go along with what I did last year. That was my default position. I'm sure that's true for most people, because you've got your job to do. That's a bad idea. It's important that you do a number of things with respect to how you decide to insure yourself. Compare costs. If your organization or the benefits provider has an expense calculator that can be used so that you can figure out what your potential expenses are, then use that. Include add-ons if you can in the package that you've got. One add-on that apparently is available, which I wish I had invested in, is pet insurance. Because it's $500 every time. Whatever it is, it's fine. I digress. You should include the cost of benefits in the budgeting that you do for everything else, because those costs need to be looked at in the same way. And then you can maximize other savings vehicles like 401ks, so that if your company's got a matching system, then you're using whatever leverage you can. So calculate. Advocate. There are lots of patient advocacy groups, especially organized around diseases. There's also something called the Patient Advocacy Foundation, which exists to represent the rights of patients in dealing with the sort of problems that they have. I think that patient advocacy is going to become more and more significant in the future as some form of consumerism, which Joe was talking about, becomes more a part of the way that healthcare is managed. And the fifth one.
So, the reason it says ruminated because it rhymes with calculated advocacy. So I didn't like the word ruminated, but I guess.
I thought you did.
I think it would ponder.
Oh, okay.
Ponder. So what do you ponder? Well, you ponder the things we talked about before, whether healthcare is a right or a privilege, whether it should be affordable to all, the right public-private split. Take a position and do something about it.
So here's the concluding slide. Conclusions. The current system performs badly and is not sustainable economically. Therefore, change is essential. The power of entrenched interests has made it difficult to change in the past, but there are reasons to believe that those changes may take place. Beneficial changes may take place in the future. Positive, the original version of this said positive change is impossible in current climate. And it seemed like that was a little bit too emphatic. So let's leave it at seems impossible, but let's face it, right now is impossible. But that will have to change. That will have to change. And it will change when people who are prepared to argue the healthcare case are back in Congress. That was obviously the case in 2010 when the Affordable Care Act was passed, and it will be the case again. And I put a little dig in here about climate change because, you know, it seemed appropriate to do that, but I'll leave it at that. And Joe.
And positive disruption emerging. We talked about telemedicine and food access, value-based care. We talked about that. Those are all really great positive things. Disruptive technologies and consumer activism, fantastic. Innovative startups. I'd like to end just before the last thing to say with the following statistic. In 2019, 7.5 billion of venture capital money went into healthcare, primarily digital health. In 2020, that number was 14.1 billion, twice as much. In 2021, the first quarter of 2021, 7 billion, Washington, 7 billion went into healthcare. And so if you extrapolate one quarter times 428, that's 28 billion if you extrapolate for 2021. That's twice as much as what was spent for 2020. You have to do it, and they're all claiming we are creating cheaper, more convenient, more effective healthcare. With all this money going in, you cannot believe that some of it is going to come through.
Hope so.
I hope so.
And lastly, and most important,
Can we see that together?
oh, sure. Let's
You
take it.
can take action now
to protect your interests and your health. Thank you very much.
So I think you can just read if you want to, but we're open for questions. So.
And would you please address your tough questions to Joe?
And how do we put them to?
Yes, yes, so.
Very much. But one of the questions that I think it's difficult to compare outcomes between different countries because the culture is different. People eat different foods. People in some countries eat a lot more healthy than people do in the United States. They have a food industry that's very often completely disregarded healthy foods. When you go to the supermarket in certain parts of the United States, when you look at what people have in their grocery cart, you say, "God, how can these people? How long are they going to live?" So could you address
Yeah, so I'm going to repeat the question because Michael told us to repeat the question for purposes of the people who listen to this on YouTube, I think. So I'll repeat the question and you'll answer.
Sure.
Okay? Is that a deal? Okay.
Yeah.
So the question is, how can we compare different countries when their cultures, when their eating habits are so different? Is it meaningful to compare? Is that a good paraphrase?
Okay, so on the one hand, these differences are real, and so they have to be taken into account. But in the end, they don't mean that these comparisons aren't reasonable and indeed necessary. And if they're not made, then the danger is that one will sort of simply accept a deterministic model which says, oh, well, we can't do anything about high diabetes rates. Diabetes is linked to obesity and a lack of exercise and diet. I'm going to go way off piece here and say something I probably shouldn't, but I'm going to say it anyway. When I was running the healthcare analytics business, it was headquartered in Ann Arbor, Michigan. That was my first real introduction to working in the Midwest. And this is a business that advised both providers and companies and payers about what best practice was, the way you deal with the population, and how you can encourage a population to eat better, take more exercise, and what have you. My overriding impression when I got to working in another in the Midwest was simply how large things were, and how apparently overweight many of them were. Okay? Now, this was not a kind of dismissive and patronizing British type thing. It was simply an observation of this. Now, if what you said was sort of indelibly the case, we'd sort of give up on the Midwest and say, well, you know, the Northeast and the West Coast, you know, are by and large thinner and handle diabetes better. We can't do that. What we have to do is to have a public health strategy that persuades people that they can and will change. So your question is, it's a brilliant question, but I think the answer to it sort of has to be that.
And I just want to add to that, I agree with that. So now about the last part. Okay, so, but I think you have to ask the question, the question is it better to do these analyses knowing that they're imperfect, or should we ignore them? Do they add value to our body of knowledge? I think that's how I view it. And I think they do add value even though they are imperfect, because you can't really, it's a little bit more oranges and apples, you'll never get oranges and oranges. Okay, so thank you. Next question. Okay, yes.
This may be beyond the scope, but I'm wondering, you know, you say protect now, you know, protect your future. What about catastrophic illnesses or accidents that could have in financial rules? Because basically, you have, if you don't qualify for Medicare, your breadwinner has a catastrophic illness or accident. Now you have to Medicaid, but you can only have a certain amount of money in your name. They wipe out everything you saved for, everything that you have worked for. Do you have any suggestions for?
You want to do the question? Oh yeah, what do you do in order to handle
And protect yourself.
and protect yourself against the catastrophic event? That's summary of the question.
Yeah, even with someone say my age that doesn't qualify for Medicare, but even people who, you know, they're on Medicare, maybe they have insurance through retirement and have a certain amount, but things happen. So how do you protect yourself against these situations?
Okay, so I actually don't have a very good answer for that. I think it's I don't have a good answer for that. So why don't you go first?
I thought you handled that brilliantly.
Thank you.
Really good. So smooth.
Yeah.
You know, the answer is there isn't a completely satisfying answer. The points that you made at the end are the direction in which one should go. By definition, a catastrophic event is something that you don't want or need to completely plan for, because it's not realistic to do that. I think that when you make your choices with regard to the insurance that you buy, when you look at the kind of financial nest egg, let's call it, that is realistic and reasonable, then you're beginning to sort of think about what you would do if something unimaginable happened. But it is unfortunately the case in the US that there isn't a sufficiently clear and robust safety net when these things.
Okay, I actually brought up something else to say. That is, you know, I talked about the annual out-of-pocket maximum. So I remember with my insurance policy when I was employed, that there was an annual out-of-pocket maximum. So if you have I might be wrong here, but I think if you have the appropriate, check your insurance policy. If you have an employer-based or responsible insurance policy, they normally have an annual out-of-pocket maximum. So it should not be. Check should not be a problem. Because if you do have a catastrophe, that's what it's.
But if the person who is employed carries the insurance.
Okay, now, so that's the gap, but I don't know how to answer that. That's a really, that gap. I go back to what Michael said. Next question. I think there was a name in the back. Yes.
Yeah.
Maher.
Hello.
Hello, Maher.
That graph there was the US has this amount of innovative insurance, the quality of the medical treatment in the US is very low. I just wonder where was the data from, because from what I know, actually, we have one of the least medical.
Question is, we had a graph that showed the USA is in fact not number one, but last. And the question is, where did that information come from in view of the fact that medical treatment in the US is often of the highest quality? Is that a fair summary of your, yeah. You have put your finger on the difference between the healthcare system and medicine per se. So what we tried to communicate was that when it comes to treatment, the USA is as good as anywhere and probably better than most. Where the problems are with coverage, the previous question, potentially with access and with certainty. And so the 5 criteria that we used in the performance evaluation were 4 of those criteria were about access, about outcomes, and how medicine is accessed. 1 was about the care process, and that the USA came out number 2, and was probably close to number 1. So the situation here is one where I have experienced this absolutely. The medical care here is often of the very highest quality, and if one has access to it, then it's all good. But the problem is with that access.
Can I have you say?
Thank you.
David,
Yes, please.
It's not a question. I just want to talk about the cutoff and maximum out of pocket. I sold benefits for 50-some odd years. And I can't remember the last time we wrote a plan which didn't have a cutoff of a certain amount, which transfers the problem to the insurance company, no matter what. And unlimited maximum were very common. First, were 250,000 years ago. Then they were $1 million in the time. And people realize, realize $1 million or $1 million is fine. So it is very, you make it common. It's very, very important to look at what you're being offered. And people naturally, when they're not sick, say, geez, I can save a little more, about $20 a week more if I take the cheaper medical plan. But then they wind up with a catastrophic, not many people, but many do have a catastrophic illness or accident or whatnot, which requires the better coverage, and they're a spot where they can't redeem that decision until that.
Yeah, absolutely. And the point that I think would be that a decision to go a certain way and save the $20 should be a calculation. It shouldn't just be about costing. And if you make that calculation, then fair enough. You know, there's a trade-off. But be aware of what that trade-off potentially is.
But it does create high costs.
Right. Right. Okay. Well, one more. Thank you.
I just want to hear really wonderful presentation. Just lucid and engaging in way that I do have, it's not exactly a question, there's one thing I'd like to have from the table and more about. There's an organization which I'm sure you're familiar with called Petitions for National Health Care, PNHP.org, right? And I have often gone there to read their articles. These are people who, like yourselves, are intelligent and lucid, and many of the doctors, of course, the name of the and there are other professionals, and they are dedicated to the possibility of a single plan. And so, as I say, I've just sort of gone that from time to encouraging. So that having been said, I was kind of disheartened to really say that you thought there was no possibility of a shift to when you heard the social American and I suspect you're probably right, but I wanted you to just say a little bit more about that.
Okay, so I'll repeat the question. But that you were a little bit disappointed with the end. You were disheartened by the fact that you don't think that there will be socialized medicine in the United States. That there will be a single payer situation that the government, that we don't think of that as a possibility. Could you make that statement?
Yes. The course of this presentation, I was like,
But when I asked you to do one, it's more the imperative. Yeah. Michael.
thank you. It's a big question that we've been talking about for a long time. I think that what I was saying is that imagining the extent of the change and the likely opposition from the entrenched interests within healthcare, if one looks at how difficult it was to introduce the Affordable Care Act, which was the only structural change since 1964, if one looks at the failure of repentance to effect change, and if one looks at the current political climate, then doing something as frankly as big and really as bold as completely rewriting the system seems to me to be a step too far. And that's just from a realistic point of view. It's not to say that there is an argument for it, and there is, but I just don't think it's going to.
The American Dental Association, originally when Medicare came out, they pushed and they did not allow dental to be covered by Medicare. And most recently, Biden started to include dental into Medicare, and the American Dental Association again uses it. So I'm just adding to his argument that it's so hard to get the things that you think we should be getting. So can you imagine such a dramatic change? The realism of that, how realistic that is.
The last one, yes, okay.
Currently, there are some procedures in the US that are not covered by the insurance company, because we look at them as experimental. How is that covered in the social system?
I think that would depend on how our experimental procedures are covered in other countries. I think that will vary from country to country.
But I would guess that since they cover just basic care, I would think it'd be a hook for them to cover something special here or experimental. I'm just guessing that that's probably. Thank you.
Okay, we'll leave it. Okay, thank you very much for coming. Thank you.